Thank you for inviting me. Today I'm going to be talking about screening for cancer in nursing home patients. And the title says it's almost always a bad idea, which it is, and that's what I'm going to be explaining today. In addition to nursing home patients, much of what I say will be applicable to any frail older person. This is going to be a new idea, I think, for some of you, because what I'm going to be talking about is too much medicine can be harmful. And really my favorite example is screening for cancer in nursing home patients. Too much medicine can be bad for you. This is not the way we normally talk. We certainly don't talk this way about screening for cancer in nursing home patients. We talk about cancer screening. Everyone should get a mammogram. Everyone needs to get colonoscopy. We're always talking about how not enough people are getting screened. And yet what I'm going to be talking about is too many people sometimes getting screened. So about a year ago, it could have been 2 years ago, there was a big controversy in this country when the U.S. Task Force on Preventive Medicine came out with a series of recommendations, which I'll review in a little while. But one of them was, golly, maybe we're doing too many mammograms. Not in nursing home patients, but in all women. And so they changed their recommendation from that everyone over 40 ought to get a mammogram every year. And they changed that to women age 40 to 50 should talk to their doctors about whether it was a good idea to get a mammogram. And then women over 50 should get one, but every 2 years. And there was a huge controversy, a lot of it framed in the context of this is rationing, that they're somehow depriving people of what they need. And what I'm going to try to convince you of today is that had nothing to do with it. This is not an economic issue. This is a medical issue or a human issue about what's best for the person. And so all of these recommendations in terms of not doing as much screening is because with less screening, overall it results in better health for the population. So what is cancer screening? Just so we're all clear on what we're talking about. Cancer screening is when you do a test to detect cancer in someone who has no symptoms. So if you have a patient who's got a lump in their breast, or you have a lump in your breast, and you get a mammogram, that's not screening. Or if you have problems with your bowel movements or whatever, and you get a colonoscopy, that's not screening. So nothing I say today will have anything to do with what we call diagnostic tests, which is tests driven by someone with a problem. This is all tests that you do on a perfectly healthy population to look for a problem. So why do we screen? Well, we screen because with cancer, it's true typically that the earlier you diagnose it, the smaller the cancer is when you diagnose it, the easier it is to treat. And so typically with tests that detect cancer like mammography or colonoscopy, you'll detect it long before it becomes big enough to cause a problem. And so you're picking up these cancers when they're much easier to treat and much more easily curable. So screening can't hurt, can it? And I think that's the dominant attitude that many of us have had for a long time, which is, well, why not get it? It's not going to hurt. I mean, it may not help, but at least it won't hurt. And as I will be laying out my argument is no, it actually hurts. And so the reason to do it is because it can be harmful. The reason not to do it in certain populations is it causes more harm than good. So let's go through the potential benefits and harms of cancer screening. So one benefit, obviously, is the one we talked about, which is you find it earlier when it's more easily treatable. In addition, some cancer screens are not only screens, they actually result in lowering your chance of ever getting the cancer. So, for example, cervical cancer was the #1 cause of cancer deaths in women and the #1 female cancer in women in the 1930s. But then when the pap smear came in, it went down to very, very low. And so what a pap smear does is it not only detects early cancer, that's actually a failure of the pap smear. The pap smear detects abnormalities long before they become cancer. And so a pap smear actually prevents cancer because the doctor can treat it before it ever gets there. Similarly, colonoscopy, you're removing polyps before they become cancerous. And so the actual rate of cancer development decreases in a country when you do pap smears and colonoscopies. And both of those two things, one is getting it early and the other is actually preventing the cancer from happening to begin with, lower death rates from cancer. Now, with other cancer screens like PSA and mammograms, they don't actually prevent cancer, they just help you pick it up earlier. So what are the problems? Well, one problem I think probably everyone's aware of is a false positive test. False positive test leading to other problems. So if you ask a room full of women about their issues with mammography, you will probably hear stories about how they were called back and they had to get a biopsy and they went through maybe 3 or 4 weeks of hell worrying about whether they had cancer before it was finally determined that no, they didn't. So we've known about that. And then there are complications from the cancer screen. For most tests, the complications are not great. For a mammogram, it's uncomfortable. For a PSA test, it's just a blood draw. For a cervical pap smear, it's once again uncomfortable. But they're relatively minor complications. For a colonoscopy, it's actually very important complications. About 1 out of every 1,000 screening colonoscopies in older people, in people over 65, results in a hospitalization. And actually 1 out of every 10,000, they die of the complications. So that's rare, 1 out of every 10,000, but when you're talking about applying this to a population, that adds up, and then you have to remember that the benefit is not overwhelming. I mean, 95% of us will never develop colon cancer, so it can only benefit the 5% that are going to get it. And so we have to be careful to balance the benefits from the risk. Now, in the normal population, in people, in men and women over age 50 to age 75, there's no doubt that with any of these, with the colonoscopy and with the mammogram, and with the pap smear, there's no doubt that the benefit far outweighs the risk. And that's why our major message from physicians and from public health experts over the past 30 years is, get your mammograms, get colonoscopy, get your pap smear. But for certain populations, including the frail elderly and those in nursing homes, that's when we get into a situation where the risk starts outweighing the benefit. So let me just go through a couple of examples now of some of these problems. This is the number of false positive tests. So this is like if you have a woman who does not have breast cancer and she gets a screening mammogram, what are her chances of being told, hey, you have to come back for further testing? And as it's shown there, about 7.5% of all women in the Medicare age who come in for a mammogram who don't have breast cancer will still get called back for additional tests. 1% of them will get biopsy. And what that means is that if you're a woman and you come in every year for your mammogram, after 10 years, you'll have had a 1 in 10 chance of having a biopsy. So that's a price we pay. It's not an overwhelmingly terrible price, but it is a price in terms of side effects of a screen. Much more important, and one that we really haven't paid attention to until recently, is the problem of overdiagnosis. And I would still think that the vast majority of Americans are not familiar yet with the concept of overdiagnosis, and even there are still a substantial number of physicians and nurses who are not all that comfortable with the concept of overdiagnosis. And what overdiagnosis means is when you find a cancer that would otherwise never have bothered the patient. So there is no doubt, and I will go through some of the evidence with you, that this happens, that when you screen, you find cancers sometimes that never would have become apparent during that person's lifetime. They would have lived happily ever after, never knowing that they may have had a cancer. And when you find it, then what happens is you have to treat it. And so that means that people are getting diagnosed and treated with surgery or radiation or chemotherapy for diseases that they never would have been bothered with in their lifetime if the screen had not been done. So this is a complicated slide. And what this does is it describes kind of the trajectory of a cancer. It actually describes four sort of sample trajectories of a cancer. And on the vertical axis is the size of the cancer. So all the cancers start down in the lower left-hand corner of that graph when they're like a cell and they start dividing. And they can start dividing fast or they can start dividing slow. So let's just take that slow, that line that says slow. And now on the horizontal axis is time. So over time, the cancer divides and grows and grows and grows over time, and it gets bigger and bigger and bigger. And then finally it gets to a point, which is this dotted line that says size at which the cancer causes symptoms. So this is, you know, if this is a colon cancer, maybe this is when people start having blood in their bowel movements. If it's a breast lump, it's when a woman feels the breast lump. If it's a prostate cancer, maybe it's when the man has trouble urinating. But it causes symptoms, and then they go to the doctor to get it treated. So the goal of screening then is to pick up that cancer before it causes symptoms. Because at some point it gets to that top line, unfortunately, where the cancer kills the patient. But as I say, there are sort of four trajectories. We have one called fast and slow and very slow and non-progressive. And so it really depends on the cancer whether screening helps. So for example, if you're on the fast trajectory, what that means is the cancer is growing very, very fast, and it goes from barely there to causing symptoms to killing you in a very short period of time, which is an unpleasant concept, but it happens in medicine. Many lung cancers are like that, and that's why we've had the devil of a time developing any effective screening test for lung cancer. Even in high-risk populations like cigarette smokers, it's very hard to come up with a test that works very well, because by the time people are in that state between when the cancer first starts and when it causes symptoms for a relatively short period of time, and so it's very hard then to catch it before it causes problems. And then there's the slow, and that's the ideal state. That's true for most breast cancers, and it's also true for colon cancers. And so there's a pretty long time there during which that cancer is growing, when it hasn't caused symptoms yet, when maybe a screen can pick it up and we can treat it before it's symptomatic, and presumably we can come up with a treatment that's more effective because it's smaller. Now what we don't want to do is detect cancers that are on the very slow growth rate, because what happens is over on the right-hand side of that graph is a line that says death from other causes. So that means you're 62 and you get diagnosed with something. Or let's say you don't. You develop a cancer. And it slowly grows and slowly grows and slowly grows. But it grows so slowly that when you die at age 81 from a heart attack, you still don't know you had the cancer. Now, if someone diagnoses that thing when you're age 68, and you undergo surgery and chemotherapy, you've gone through something that you didn't need. You've subjected yourself to treatment that you didn't need. Ironically, you'll be grateful because you think you will need it. No one will be able to say, hey, you didn't really need this because you're going to die at 81 before it becomes a problem. You don't know that. So you're very grateful, and I'll show you some examples of that. But you didn't need it. And then some cancers are non-progressive. Many prostate cancers are non-progressive, which means they grow a little and then they just sort of stay there and they don't get any bigger. And it would be, criminal to diagnose them because then and we can't, once you diagnose it, you can't say, oh, well, this one's non-progressive versus this one's not. You're just left with something called cancer. And so what happens is those cases get treated and they get subjected to treatment that person didn't need. One way of looking at it is, let's say there's a woman, a 55-year-old woman, and she's in New York or San Antonio or somewhere, and she goes to her doctor and gets her mammogram, and the doctor says, oh, there's a small lump, and she gets further testing, and it's a cancer, and the doctor says, well, it's lucky we caught it when it was still small, and she gets a surgery, and then she gets chemotherapy, and she gets a little radiation. And she goes through hell for 4 or 5 months. She has a rough time, as you might imagine. I'm sure some of you who are listening have been through a similar situation. You know it's a tough time. But on the other hand, she feels very good about it because they caught it in time. And then about a year later, she's back to normal. Her hair's grown back. She's back at her job, and everything's feeling fine. And she's walking along the street, and suddenly she's attacked by this lion and eaten. Now, maybe it wasn't New York. Maybe it was some other place. Or maybe the lion escaped from the zoo. But the point is that sometimes stuff like that happens, okay? She gets run over by a bus. She gets squashed by a giant rhinoceros. She has a aneurysm in her brain break. Now, I'm saying things to really bring any audience I have down into Great Depression by talking about all this stuff. But this happens to people. Now, so what's important to understand is that woman would have been better off had she never gotten a mammogram. Even though everyone followed the rules, even though they treated her cancer and cured it, she would have been better off because a year later she still would never have known that she had cancer and she would have died of another cause. Now, obviously we can't predict that, and that's why we recommend that women over age 50 get mammograms. But the point is the older we get, the more lions there are out there. The older we get, the more other things come along which are going to shorten our life or at least end our life before we benefit from screening. And then what we're doing is we only have the bad effect of treatment without the benefit of having a life extension. So let's go through a couple of examples, but first I want to review what the current recommendations on screening are. And these have changed over the last couple of years, and they've changed rather dramatically because of new data from very large studies. And what I have on the left-hand column is the recommendations from the United States Preventive Services Task Force, which is a group of primary care physicians and cancer specialists. They're beholden to no one. Their recommendations are just based on what they think is best for the patient. This is not an economic agenda. It has nothing to do with saving money. It has to do with what's the best way to screen and reduce the health burden of cancer in this country. And then the American Cancer Society is on the right-hand side. They've always been relatively more in favor of screening, and they've changed also recently, which is really quite unusual. So for mammograms, as I said, the current recommendations, and I think probably a lot of people don't understand this yet, but the current recommendations are you get it every other year, starting at age 50. This is not to say you shouldn't get it during your 40s. If you have a first-degree relative who had cancer, then you get it earlier, or if you've had cysts in your breast, or various other reasons. There are a lot of reasons why you might want to get it in your 40s, but it's no longer routinely recommended for all women, and it's not recommended for every year anymore for all women. It's recommended every other year. The reason is, once again, it's overdiagnosis. What happened when we started doing routine mammograms every year on women starting at age 40 is we wound up with about 20% more women diagnosed with breast cancer than ever had it before. And we thought, oh, that was just a phenomenon, it'll come back to normal, but it never did. And so, and in particular, women in their 40s developed something called carcinoma in situ, ductal carcinoma in situ, or DCIS, and we were getting an epidemic of them, and those women would get radiation or a mastectomy. And it turned out that before we had mammograms, we weren't picking them up, and those things tend to resolve on their own. So that's what resulted in the change in recommendations, and why we should be spacing our mammograms every couple years rather than every year, because we're not going to be making as many overdiagnoses or false diagnoses, and yet we'll still pick up the cancer in plenty of time, because breast cancer tends to be a relatively slow-growing cancer. For colon cancer, I listed, it's rather complicated, but I listed all the ways you can get screened. You can get what's called a fecal occult blood. That's where you give a little stool sample your bowel movement to the doctor every year. Or you can get a sigmoidoscopy, which is something about this long, that gets sticked up your rectum every 5 years. But what most people now do is they get a colonoscopy. And the recommendation for colonoscopy is to get one every 10 years. And I'll show you a little justification for that. And the recommendation also is to stop screening at age 75. Now, anytime, I'm a geriatrician, and anytime people say, well, don't do something over 75, you immediately think, oh, this is rationing. Once again, it ain't rationing. It's what's best for the patient. That as we look at life expectancy of people over 75, and we look at the potential benefits of a colonoscopy, and we look at the natural history of colon cancer, in other words, how slowly they grow, then those side effects of colonoscopy that I talked about earlier, the hospitalizations and the very infrequent deaths, even though they're rare, become of a weight which is heavier than any potential benefit of colonoscopy. And then for prostate cancer, this has perhaps been the one screen where there's the most controversy now and the most change in opinions. I mean, up until 2 years ago, the American Cancer Society was recommending PSAs for everyone over age 40, and now with these 2 new big trials of PSA, which really showed almost no benefit and a lot of harm from screening PSA, the American Cancer Society has backed off and said it's an individual decision. And the U.S. Preventive Services Task Force has never recommended PSA because there's never been any good evidence that it did any good, and there's increasing evidence that it can cause harm. So what are the problems with the PSA screening? Well, on the one hand, it's incredibly widespread. I'll show you a little data from Texas on that. And the American public has bought into it. PSA is more prevalent now than getting a mammogram. The problem is that why do you get a screen? Well, to pick it up early, to pick up cancer in early stage, because the earlier the stage, the more likely that the treatment will be effective. Well, it turns out for PSA, it doesn't matter as much. In other words, like if you get diagnosed with a small breast cancer, that's a heck of a lot better than getting diagnosed with a breast cancer that's already spread to your lymph node in terms of how much treatment you need and your chances of survival. But with prostate cancer, stage 1, 2, and 3, sort of the first 3 or 4 stages, all people survive about the same. And then, as I said, we've had 2 large randomized trials that showed very little benefit and a lot of overdiagnosis. And in terms of overdiagnosis, the number of men in this country who now go around with a diagnosis of prostate cancer is twice as much as we had before the PSA. So what the PSA has done is it's doubled the diagnosis of prostate cancer. Those men, those twice as many men, half of those men who never would have been diagnosed during their lives, but now get diagnosed, treated, suffer the side effects of treatment, and, ironically enough, are grateful because they don't know that they were overdiagnosed. They think, oh, thank God, the doctor found it in time. So I mentioned that no one, the American Cancer Society, the U.S. Preventive Services Task Force, no one recommends PSA screening in populations with less than a 10-year life expectancy. Here are data looking at the percent of men in Texas, all the men in Medicare in Texas who get a PSA every year. And even, and the purple line is, I mean, whatever that color is, the blue line, chartreuse, it's one of those weird colors, aqua, is men over 85. And 40% of men over 85 in this country get a PSA test. Now, that's awful because you cannot define a cohort of men over the age of 85 who have a life expectancy of 10 years. Even if, if you take men age 85 who are in the best possible physical condition, still their average life expectancy is under 10 years. And certainly there's no way that 40% of men over 85 have that type of life expectancy. And yet that's the rate of PSA screening. So here's the other point about, this is a little complicated, but what this is a survival curve. And so at the left here is when you get diagnosed, and then along the horizontal axis is months. And then the different lines are how big is the prostate cancer. So stage 1 is a prostate cancer that's small, that stays in your prostate. And stage 2, somewhat bigger prostate cancer. Stage 3 means it's already gotten outside your prostate, and so it's eroding into something else. Now, stage 3 we consider really bad. And then stage 4 is when it's metastasized. In other words, it's spread to bone or some other organ. And this is the point that is a fundamental reason why we don't gain much for screening for prostate cancer. Because whether you get diagnosed with stage 1 or you get diagnosed with stage 3, the treatment is about the same and the survival is identical. So you don't gain anything in terms of survival by getting diagnosed early, except if you avoid stage 4. So this isn't true for any other cancer. It's certainly not true for breast cancer. The earlier you get diagnosed, the better. It's certainly not true for colon cancer. But for prostate cancer, the vast majority of men are being diagnosed with stage 1, 2, and 3, and they all have almost the same survival. This is just a graph showing us what's happened to the diagnosis of prostate cancer, the number of men diagnosed with prostate cancer in this country after the PSA was introduced. And so once again, it used to be that a man had about an adult male had about a 1 in 1,000 chance of getting diagnosed with prostate cancer every year. After PSA came out, it was about 2 in 1,000. So it more than doubled, a little more than doubled your risk of getting prostate cancer, which means then getting treated and all that. And those people in between, that million extra men, it's been calculated that there are 1 million men in this country who have been diagnosed with prostate cancer because of PSA testing, who, if we hadn't had the PSA, they never would have been diagnosed in their lifetime, and they never would have been bothered by the cancer. They had the cancer, it's just they never would have been bothered by it. So that's the reason for these recommendations. Especially for why the United States Preventive Services Task Force doesn't currently recommend PSA screening. And I think these recommendations are in evolution. I would not be at all surprised if PSA testing sort of evolved out of medicine over the next few years, because There's very little data supporting its use, and there's more and more and more data showing it can be harmful. For colon cancer, it's obviously incredibly useful. It's already resulted for colonoscopy. It's already resulted in a decrease in colon cancer. It's resulted in a decrease in colon cancer deaths, but there's an upper age. And let me just go through some of the rationale for that upper age. This is data that was accumulated before colonoscopes had been made popular, actually before they had been put into use. And so this was data from the 1960s and 70s in the Mayo Clinic, and they diagnosed people with large polyps. These are greater than a centimeter polyp. These are the type of polyps that get doctors excited these days. These are large polyps. They were diagnosed with a barium enema, which is, where they take x-rays. But back then, since they didn't have colonoscopes and they didn't want to do an operation just to remove a polyp, they just left them alone and followed these people. And then this shows if you have a big polyp, how long does it take for that polyp to develop into cancer? And so by 10 years afterwards, fewer than 10% of the people with these big polyps develop cancer. Now, the reasoning is then, if it takes 10 years for like 8% of people to develop cancer with a large polyp, then if you get a colonoscopy and you're clean and you don't have any polyps, then having a 10-year span is more than enough. It gives you plenty of leeway in terms of picking up something new. And so that was the justification for why colonoscopies are recommended every 10 years. The reason I'm emphasizing this is we did a study a few months ago that showed that about half of people who have normal colonoscopies, totally clean colonoscopies, half of those people are coming back in less than 7 years to get a repeat colonoscopy. So they're subjecting themselves to the harms of colonoscopy, but they're not getting any additional benefit than if they had waited for 10 years. So let's get to nursing homes, since that's what this talk is supposed to be about. And the fundamental argument against cancer screening in the nursing home is that older patients in a nursing home will not live long enough to benefit from cancer screening tests. So everything I've been talking about in overdiagnosis comes into play very much in nursing home patients who have a shorter life expectancy. Sad but true, we all are aware of that people living in nursing homes have a relatively short life expectancy, so they won't be able to benefit, will be picking up cancers that otherwise wouldn't have bothered them, and they're going to get treated for them. And so we're going to be subjecting them to the side effects of screening. We're going to be subjecting them to diagnosis and treatment, but without much benefit. So let's go into the evidence that older people in nursing homes don't live very long. I think we all realize that, but it's good to review the evidence. So what we're talking about here is, to go back to this trajectory then, we're talking about cancers that are on that slow trajectory, where normally if you're 50 or 60 or a healthy 74-year-old or whatever, you're going to benefit from screening for cancers that are on that slow trajectory. But what happens with the nursing home patients is that death from other causes gets slid to the left, and death happens before the benefit does. So I'm going to show you 3 survival curves. And these are curves where you start up in the upper left-hand corner and you get a population. And at the upper left-hand corner means 100% of those people are alive. And then as you go down, you get to where it says 0.8, that's 80% of them are alive, or down to 60% of them are alive. And that's over time. And so this curve just shows 3-year survival from a very, very large nursing home population, several nursing homes where they followed the survival. And this was separating them by a chest scale, which is just a way of looking at their overall health, including functional health and mental health, to see if we can separate them to predict people who will live the longest. And even taking the population that has the highest score, it's less than 50% of them will be alive in 5 years. There's not 5-year survival here, there's only 3-year survival, but if you project it out, it's less than a 50% 5-year survival. You can look at the same thing with activities of daily living, which is a good way of predicting survival in frail older populations. And once again, people who are good in their activities of daily living, have good scores, still have a very challenged survival. And you can look at it in terms of their social engagement, which is another, interestingly enough, it's a good predictor of survival in institutionalized population, how engaged people are with other people. That's why good nursing homes spend so much time trying to do socialization, because it does seem to matter a whole heck of a lot. Typically, a rule for frail older populations is if it affects quality of life, it's going to affect quantity of life. You know, if you do something that makes people happy, they're also going to live longer. And so, but once again, unfortunately, we can't find a population here that has a 5-year survival of 50%. So this is, once again, I'm probably making many in the audience rather depressed going over all these data about how people die, but this is the facts that we deal with. And just remember then that you don't want to diagnose something in that population which wasn't going to bother them for another 7 or 8 years, and yet we diagnose it and then treat it. So one other issue that I'd like to bring up about cancer screening in nursing home patients. And by the way, the reason I'm doing this is there's plenty of cancer screening going on in nursing home patients. I mean, if this were not a problem, I wouldn't be talking about it. But we have data to show that a lot of women, a lot of very frail women in nursing homes are getting mammograms. As a matter of fact, some people are publishing articles saying we're not doing enough cancer screening in nursing homes, and it's an underserved population. And so it is a problem. It may not be a problem in every institution. If it's not a problem in yours, that's great, but it is a problem. So the other issue that I find that I've had a lot of sort of personal relationship with, and I'm sure anyone who's a caregiver has been in this situation, is when you do any test in a cognitively impaired person, if you do any test in someone with dementia, with Alzheimer's disease, suddenly it's in a different dimension. Suddenly it's not, hey, look, I got to take a little blood, hold your arm, it'll stick, right? They're not going to remember that, right? So I think many of you have probably been in a situation where you had to get a test. It was important that you get a test, whether it was a blood draw, and something that was really routine became a traumatic experience. I mean, if you can imagine, you know, someone from the perspective of the cognitively impaired patient, they've forgotten the explanation. Suddenly there are these two people who are murmuring at them, and one of them's holding down your arm and sticking a needle in. I mean, it's like out of a bad movie, all right? And so what I'm saying is the price of getting the test is much higher in a cognitively impaired patient, at least can be. Some cognitively impaired patients can be quite docile and do anything, but it can be. It would be like an assault. It would be like people breaking into your room at night and assaulting it for some of these patients. So that's another price that cognitively impaired patients may have to pay for any test, and it makes clinicians then, I think, much more modest in our need for information. Because if we know that the personal price that the patient is going to pay for that information in terms of emotional distress is higher, then our need for information is ratcheted down. We have to take that into consideration. So there are challenges to reduce screening. And not just in nursing homes, but anywhere there are challenges to reduce screening. And one problem that has bothered me is that almost all the arguments thus far for reducing screening are framed in economic grounds, like it's wasting the government $1.1 billion a year. Well, no one likes economic, when you're thinking about your health or your mother's health, you don't want to be told, well, we're doing this to save money. That sounds like rationing. And it isn't about the money. It's about the health. It's about what's best for that patient. We published a study this year that got an enormous amount of publicity that was talking about overuse of colonoscopy. And I must have done 30 interviews with reporters or radio interviews. And every single one of them wanted to focus on the costs. And I said, look, I don't want to talk about costs. I want to talk about the human costs, because if you talk about the costs, people just think it's rationing. And I would say I was successful in maybe 2 stories out of 30 in getting my message across, which is this is doing what's best for the patient, not what's cheapest for the healthcare system. And then the other thing I've already talked about, which is no one goes around saying, I've been over-screened, I've been over-treated. No one knows if they've been over-treated. They just know that they got a test, the doctor found a cancer, and it got treated. Thank God they found it in time. So there's no reward. No one's ever going to get sued for over-screening. And the converse, someone might. So there's no big motivation out there to reduce over-screening. So some of the issues in cancer screening then, this is, when I started out back in the old days, someone went to the doctor's office, I made a decision, and that's what happened. Of course, times have changed, so now everything is shared decision making, and in particular when it comes to cancer screening, there's tremendous ownership of public ownership of issues about cancer screening. I find out about new findings at the same time my patients do. My patients respect my advice, but they also get input from their children. They get input from lots of different sources, and there are some strange attitudes out there. And I'll just show you one example of strange attitudes. This was a study that was published in JAMA, Journal of the American Journal of the American Medical Association, about almost 10 years ago now, that looked at, it was a telephone survey of men over 50, and it just asked them some true, false, yes, no questions, and this is just a few of them, but 75% of the men thought they should be getting a PSA test forever, even though in 2002 no one recommended that. No one. The American Urologic Society, American Cancer Society, no one recommended that men over 75 should get a PSA. And yet 75% of the men thought they'd get it forever. And then, to show how strongly they felt about it, they asked, well, if your physician said don't get a PSA, would you agree? And another 75% said no. I want my PSA. So that's the type of issues we're facing. If a question, do you feel that an 80-year-old man in average health who didn't get a PSA was irresponsible? Yeah, a third of them thought that would be irresponsible. Well, clearly that's wrong. There's no authority that would recommend a PSA test in an 80-year-old man. No authority in the United States of America who would recommend that test. And yet the public thinks that that's the right thing to do. So we face enormous burdens in terms of trying to reduce screening. So in terms of the lessons over the past 15 years of our experience, the U.S. experience with cancer screening, we know that we caused an epidemic of prostate cancer by introducing the PSA. We doubled the rate of it, which meant that 1 million more men were treated who otherwise never would have been. Mammography has been one of the great success stories of cancer screening. It's reduced deaths from breast cancer. It used to be about 27, 28% of women diagnosed with breast cancer would die of the disease. And with mammography and also with better treatment, it's down to 22%. So that's a fairly substantial reduction. So it's been a great success story. However, there has been a cost also, which is about 20% more women are diagnosed who otherwise would have never been diagnosed. during their lives. And so that's the price we pay. Everyone would agree that's worth it, that's an okay price to pay, but we certainly don't want to then over-screen. We don't want to do mammograms in people who could only be overdiagnosed and not benefit otherwise. And then screening colonoscopy every 10 years has a promise for having a major effect on colon cancer mortality in this country. It's already had an effect, but it's just beginning. I think the incidence of colon cancer, the rate of colon cancer will continue to decrease. Deaths from colon cancer will continue to decrease with appropriate colonoscopy screening. It's just that using a colonoscopy in very old populations or very sick populations or doing colonoscopy too frequently causes a lot more problems, and it has no benefit associated with it. So the inappropriate use of colonoscopy is problematic, and we have to correct it. So in conclusion, how do we reduce? I hope I've convinced you that there's really almost no one in a nursing home who should be getting cancer screening. They should be getting diagnostic tests if they have problems. If something hurts, you know, you might get a mammogram, or if they have belly pain, maybe you need a colonoscopy to figure out what's going on. But to go looking for a cancer in a nursing home patient really makes almost no sense. I'm sure that there are exceptions with people with very long life expectancies, but I've worked in and out of nursing homes for a long time, and I haven't seen those exceptions. And the way to address this is to educate the public, to educate physicians, particularly about the issue of overdiagnosis, which, as I said, I think a lot of us were not aware of until recently, and to continually emphasize it's not about the money. It is not about the money. It's about doing what's best for the patient.